So today, we're going to talk about the role of virtual simulation in patient safety. In this context, I would first give you some evidence for medical errors, and then talk about the role of medical education in reducing medical errors. And then we are going to talk about the physical simulation and the role of physical simulation in reducing medical errors. And then we are going to talk a little bit about the virtual simulation and the role of virtual simulation in supporting patient safety and reducing medical errors. Perhaps all of us have had the Hippocratic Oath. And the first thing we say there in pledge to first not do any harm to patient. So under this assumption, we lived for a long, long time because we thought we promised to not harm the patient. So therefore, we're not harming the patient. Despite many literatures that has been around in the history, like Madame Bovary, if you perhaps remember. If not, please read this book. It's very interesting on medical ethics. And also some modern press expressed the problem of medical errors, and patient actually died from medical encounters. But we ignore all of that because we thought, oh, it's separate incidences. Yeah, things happen. Some doctors are not good, but I am good. I'm always good. And I have the oath, Hippocratic Oath. Up until the landmark report was issued by Institute of Medicine in the United States in 1999, and the report was called "To Err is Human," we didn't believe anything that's scientifically proven. But this report was a wake-up call for all physicians and healthcare professionals that hospitals are not a safe place. Actually, the streets of downtown Vancouver is safer than our hospital in Vancouver. The reason for that is that the literature has showed in 1991, actually, that 3.7% of all patients coming to the US hospitals die from medical errors. And that equals about 44 to 98,000 people. The report actually increased this to 200,000 people per year in US hospitals are dying because of medical errors. And about 1 million become injured and disabled in the United States of America because of we doing something wrong, because of medical errors. The same statistics is in other countries. In Australia, it's 13.7% of people, about 50,000 patients per year suffering from disability and adverse events. And 4.9% of those people die actually from medical errors. In the UK, it's 10.8%. They divide this in 20% for cases related to surgery, but 53% is in the general wards. Canadian statistic is not better than those. We have 7.5% of patients per year are subjected to adverse events. And that equals to about 24,000 people die in Canada per year. Well, our population is much smaller than the United States. That's why it's the same statistics because of medical errors. So I don't have any statistics about India or Brazil or Europe or any other countries, but I look at the United Nations statistics, medical errors, and harm caused to patients by medical professionals is equal everywhere, if not worse. This statistics was published in the Journal of Surgery because I'm a surgeon by profession, so I thought I'm going to say anything that surgeons are not better than any other doctors and actually worse than any other doctors with respect to medical errors. And in 38 surgeons, they identified 146 incidences of adverse events that would cause 33% disability, 13% death, and 77% involve additional surgical procedures or other interventions, 67% intraoperative mistakes, 27% post-operative problems, adverse events, and 10% unnecessary advancement of disease. Aside from the ethical issues and the human suffering that is caused by physicians and healthcare professionals, this is also a huge economic burden on the shoulder of the healthcare system. So in Canada, for example, the direct cost of the healthcare system for medical errors is about $1.1 billion per year. And the Canadian Patient Safety Institute in 2019 increased this amount to $2.7 billion per year. It's a lot of money. That is the direct cost of the healthcare system. Actually, the indirect cost is much, much more. It's about $17 billion to $29 billion per year. And it may relate to additional care necessitated by the error, loss of income, household productivity, and disabilities. The same statistics for the economic burden is for Australia. Australia spends about $4.17 billion as a direct cost to medical errors. And the US, it's $19.5 billion in the cost of the indirect cost of the medical error for the United States is about $1 trillion per year. So it is a big economical problem. So in relation to the medical errors, it was also reported that the most common preventable medical errors in 2001 by the United States of America, was that it was death of the patient, permanent harm to the patient, and severe temporary harm to the patient. And all this, 90% of this happened before December to January December 2001 and January 2002. This is the time when people go for holidays and people don't really pay attention to the patients and they're coming back from the holidays. So that is I thought would be interesting statistics to give you. And most of these events are classified as a patient falls. The leading cause of patient falls include by this commission is communication failure first, and then inadequate patient assessment and inadequate safety levels or staffing supervision. So if you look at this, the communication failure, inadequate patient assessment are actually very preventable. And they're preventable by what? By education. So education will play an important role in the reduction of medical errors, in my opinion. So we are now going to go into the second phase of our presentation, that would talk about the role of medical education. So the million-dollar question here is, can medical education improve patient safety and reduce medical error? To answer that, let's look at this table that Canadian Patient Safety Institute provided as a statistical analysis. And in Canada in 2022, like right now, 1 of 3 Canadians are subjected to patient safety incidents, even now, today. And those are classified as 33% was misdiagnosis, patient fall is 30%, get an infection after treatment is 25%, mistakes during treatment is 23%, wrong medication is 21%, given the wrong medication doses is 15%, received unnecessary treatment 14%, providers gave different instructions 11%, accidentally took too much medication 8%, get a bed sore 6%, pharmacy gave the wrong medications 5%, and others 4%. If you look at all those things, actually simulation as a whole or virtual simulation in particular can support and prevent these events from coming. In this column, I have shown which one of these mistakes that are very high can be actually mitigated by virtual simulation. And then, so what kind of educational intervention is needed to improve patient safety and reduce medical errors? So this is another million-dollar question. Yeah, if education is important and the role of education is very good and the education is highly effective to reduce medical errors, then what kind of education? When I look at the literature, unfortunately, I have to say that 95% of the literature thinks that processes educational events and curricular activities that make the students aware of medical errors and to report medical errors would be the most important thing. So right now in the world, people think that medical errors happens because people are not aware of medical errors. So we should go and increase awareness by giving specific curricula, specific teaching sessions to our students, staff, and everybody else. And then some people talk about the promotional, multidisciplinary, collaborative approach to education, because medicine is a team effort and collaboration is important. And then team training is very important. And physical simulation, some people recommend. All these things are very important. I'm not saying they're not important. They're very important. But we forget about one thing: how to teach medical students and how to update staff with their skills, competencies, and knowledge to not perform, to not do medical errors. I think one of the important factors that would make a difference, particularly virtual simulation, is not mentioned anywhere in the medical literature as a factor affecting the patient safety and reducing medical errors. So to answer the question, can medical education improve patient safety and reduce medical errors? I would say yes. We strongly believe that simulation is an appropriate educational environment where students and practitioners can learn and practice competencies without legal and ethical consequences and costs associated with medical errors. Virtual simulation is more important for changing the competency-based education than anything else. Let's dive in to this issue and say, oh, why we think like that? Why do I think like that? So the first question comes is that I'm going to ask you, perhaps, but we're not in the same environment, so I can't physically ask this question, but virtually ask this question. How do we make clinical decisions? And how do we make diagnostic decisions? Research has shown that there are 4 types of thinkings. There is reduced thinking, dispersed thinking, elaborated thinking, and compiled thinking. Reduced thinking and dispersed thinking doesn't have any place in medical education because it's based on empty mind, it's clustered mind. But elaborated thinking is the one type of educational method that we use to improve knowledge, practical knowledge of medical students. And that's done by deductive reasoning. So we put the clues for students on asking questions, taking history, doing physical examination, then putting all the lab tests and things together to come up with a conclusion that we call final diagnosis, and then make management decisions based on that. But elaborated thinking is a very long process. It takes perhaps for students days to do that, or for experienced students hours. But when we go to practice, we have 15 minutes for a patient. We don't have that much time to do elaborated thinking. Then within 5 years of practice, we switch to compiled thinking. What compiled thinking is based on recall, recognition, memory. If we have seen a patient with pneumonia coming to our office 100, 200 times, that the next patient that comes in pneumonia, as soon as they get into your office, you have an idea where to put your stethoscope, what kind of specific question to ask, and what medicine to give, and how to come to that conclusion. It's not that you're ignorant to the patient, it's just we're on a different level of thinking. That's called compiled thinking. Compiled thinking is based on a recall, recognition, memory. So recall, recognition, memory was actually, the theory was proposed by Hafting. And he distinct between transfer of knowledge and transfer of learning. So transfer of knowledge is between 2 people or between groups of people. Like today, I'm exchanging ideas with you. I'm learning from you. You're learning from me. We're exchanging. This is called transfer of knowledge. But transfer of learning is from the same person to the same person. How our prior experience affects our present or future experiences that we are going to have. So the Hafting's theory is a little bit complex, but it's also very simple to explain. So what Hafting was saying is that when we have a prior encounter, the first encounter, it goes through sensory and through their reception, sensory perception, to short-term memory, and then to go long-term memory. And then in long-term memory, the brain would form semantic network that consists of neurons in pathways. It's a cluster of cells and pathways together that is responsible for a specific function. And when the next time, the second encounter, similar to the first encounter comes, the brain doesn't have to rethink. You just call that semantic network and respond immediately. And that's what it's called identical element theory. But people have asked questions to Hafting, what about if the secondary encounter is not exactly the same or identical to the primary encounter? In that case, people have developed cognitive theory of transfer. And what cognitive theory of transfer is saying that the prior encounter should not be exactly the same as the second encounter. It could be similar to the second encounter. The brain will go and pick up something that is similar. They have seen this before and build on that to build a new semantic network. Chain in 1993 actually described the stages of cognitive transfer. And he identified 4 stages. It is the connection, orientation, coaching, fine-tuning, and then routinization or solidification. So this is happening every day in medical education. We learn all the competencies through recognition of these stages. But unfortunately, we learn all these 4 stages in a clinical environment with patients. So that's why learning competencies is becoming expensive, ineffective, and it jeopardizes patient safety. So what I propose is that we should take the first 3 stages of transfer out of the clinics into the laboratories or into the virtual environment. And we can do the orientation, coaching, and fine-tuning in a laboratory environment or in a virtual environment. And when students are ready to clinical, they're in the stage of solidification, routinization, we can move them to the clinics. Nobody says that virtual environment would replace clinical or mannequins would replace clinical teaching. This is insane. Nobody's saying that. What we can say is that you have to prepare students better. Better competent students should go. For example, I give you just an example that I'm a surgeon. So when I teach my medical students knot tying techniques, when they come to my class first, when I show them knot tying technique, their brain goes, okay, these are surgical knot tying technique, but I tie my shoelaces all my life. My mother taught me how to do that. So the brains pick up those. And then when I start coaching them, new neurons would come to attach, new pathways to attach to that cluster that is already formed by student. And then they solidify slowly. Some of the neurons will go away, some of the pathways will go away, some new pathways will come when we fine tuning it. And then when it's ready to go to clinics, then you can do the knot tying techniques and supporting a patient as a surgeon in the environment. So if we do this, then the medical education will become less time consuming, less expensive, and would support the patient safety. So from here, we're going to go and talk a little bit maybe about the physical simulation and in the role of physical simulation. So before we talk about the role of physical simulation, you perhaps know that there are at least 5 types of simulation. There's live simulation, when a live person is acting on another live person, and the other live person is responding back. It's like simulated patients, a piece that you use perhaps in medical schools. There's virtual simulation when a person, a live person is acting on a machine and the machine responding back. And hybrid simulation is when the machine and a real human being team up together to support medical education and respond back to you from the emotional perspective and so on. And then constructive simulation is when a human being is acting on a machine, and the machine has different compartments, different parts. In each part of the machine can act independently, connecting with other parts of the machine to give a complex response to the person. So a virtual constructive simulation is actually the state-of-the-art technology where we can build these machines in the cloud and actually do not have the physical presence of those machines, complex machines. So this is an example of perhaps you've seen mannequins. I don't want to stay on these things. We have seen a lot of skilled trainers for a simulation of surgical procedures and things like that. And they're very effective, actually. They have a very good impact on task trainers. task trainers has a huge impact on medical education nowadays. Hybrid simulation has a good impact. It has been also proven that the surgical scale trainers have a good impact. Procedural scale trainers have a good impact. Even patient interviews, where softwares and hardwares and also live connection with SPs would improve medical education. And clinical scale trainings also have been. There are other methods, but simulation, the only problem all these task trainers and things has, that they are not giving you a simulation of the continuum of care. It will give you simulation of a point of care, a specific thing to do. But we in the hospital don't do specific things. We go and ask patients questions and then do physical examination, we do lab tests, make a decision, give IVs, fluids, treatments. So it's the whole continuum of care that is not reflected in by these physical simulators. There's this, I would say the physical simulation today has a very good status in the medical education. The American College of Surgeons were the first in the world to recognize the role of physical simulation and actually created criterion for accreditation of simulation centers. And I was very fortunate and one of small person in that committee to create those criterions. And also the Royal College of Physicians and Surgeons of Canada was also the part of that committee to develop criterion for simulation programs in accreditation of simulation programs. Today, most universities, colleges, some of the hospitals even has simulation centers. And the credentialing and licensing bodies around the world are looking to place simulation, physical simulation into the picture. However, the world has not come around to talk about virtual simulation and the role of virtual simulation in accreditation. So yes, all these things are good. They are very effective, and everybody is doing simulation, but does it reduce medical errors or prevent patient, improve patient safety? And the answer is that it may, but we don't have a direct evidence. So there are proves, plenty of papers in the world that says simulation is effective. And certainly it is effective in medical education and improving competencies, improving other skills and so on. But a direct evidence yet to come. There are glints of direct evidences, such as papers published on the infection due to central line in some hospitals were reduced significantly by introducing a simulation environment for their staff, medical staff. So, but we need a lot more research to actually prove that simulation is effective in reducing medical errors. One of the reasons why it has not been done yet in a larger scale is that the hospital environment is a very complex environment. So you cannot say just skills is just one part of the full complex environment. So the reasons you have to identify specific indicators that would reflect just that particular thing that you're doing. And at times it's very difficult. But we do have evidences, very solid evidences for other industries that simulation really worked in other industries. And one of the industries, the aviation industry. If you look at this graph that was provided by Boeing, is that before 1959, 40% of airplane that was going up, commercial and military were going down. They're falling from the skies, like popcorns. And after the introduction of simulation in the 60s, this actually reduced significantly. And now it's negligent, in relation to the number of flights on the air. The number of airplanes that falls is negligent. Of course, there are other factors on that, like we have better airports, better engines, better airplanes, better communication systems and all that, better engines. However, nobody is downplaying the role of simulation in aviation training. 70% of aviation training is on simulators. And in the 30% is theories also on online simulation. So the lectures and theoretical thing in aviation industry is just maybe 5-7%. So we believe that if the simulation did make a big difference in saving lives in aviation industry, it would save lives in healthcare industry as well. So if you look at the comparison and some stages, the stages of simulation, integration of simulation technology, we can say that aviation industry, physical and virtual simulation has gone through all phases of awareness, interested training, and adaptation. But for medical, for medicine, physical simulation has gone through most of the stages, except that it's not adapted everywhere yet. But virtual simulation is in infancy and has not been given a chance yet. So if you look at the effect in medical education culture, you see the same kind of environment that virtual simulation is. The optimal environment is not there. The accessibility is not there. It's mandatory training is not there. Licensing is not there. They don't use that for remediation and in maintenance of competency. So it's yet to come, but I strongly believe that soon virtual simulation would capture the whole attention of the whole environment. Now we're going to go into talk a little bit about the virtual simulation and the role of virtual simulation. So talking about the virtual simulation, I like to talk, there are many virtual simulators, online simulation platforms. But I will talk about maybe CyberPatient because it's my baby. We developed CyberPatient at the University of British Columbia, Department of Surgery, and also it's now commercialized. So what CyberPatient actually is, it's a virtual hospital with 135 digitally enhanced patients that that students can reach from anywhere at any time. This hospital is open 24/7, and the patients are not going to get tired no matter how many times you ask them. You want to make mistakes? Go ahead, make my day. Make as many mistakes as you want. Kill the patient, it's fine, but you learn from your mistakes. And the end, the system would give you feedback why your virtual patient died. So killing, tens of virtual patients would support you to go to the clinic more prepared and to not harm the actual patient. And also, I have to say that this is very inexpensive in comparison to the standardized patient. This is like 10% of the cost of standardized patient, so it's very cheap. And virtual simulation in relation to medical errors. We can say that it provides the environment for students to learn in virtual environment space without ethical and legal consequences. It's important because provides the environment for practitioners to improve their competencies in virtual space without ethical or legal consequences. It reduces the adverse events. It gain more, the students would gain more confidence in a non-threatening virtual environment. It improves professionalism, reduces the cost of the healthcare system, improves the quality of care, and reduces the costs for insurers also. You see, if in a normal situation, which would be the red one. So what we do usually is that it takes a year or 2 or 3 for our residents to become chief resident and actually do independent work. But with simulation, you can actually expedite this, and within 1 year you can reach the point of independency and to do more independent work in much sooner. So introduction of simulation from our perspective would make the medical education and the clinical environment safer, cost-effective, more efficient, and more reliable. I don't want to talk about these research projects in the interest of time. Perhaps you have lots. You can go to the medical literature search and find out about these papers that you have published that proves the efficacy and impact of cyber patient on medical education and clinical. So in conclusion, I would say that virtual technology such as cyber patient can be highly effective in reducing medical errors and improving patient safety if we transfer the first 3 stages of learning into a virtual space, make a virtual learning environment a mandatory prerequisite to the clinical learning environment, make a virtual clinical environment a mandatory prerequisite to entering a clinical practice. And we're doing that now. Actually, EPA's Entrustable Professional Activities is part of this. And develop a more realistic virtual space for medical practice. So I think our time is up, and I cordially thank everyone again for your attention. And if you have any question, I'll be more than happy to entertain. Thank you.